So let's begin our last lecture. This is the last lecture for this semester. The lecture is devoted to traumatic brain injury. Lecture consists of three parts. First part of the lecture about etiology, pathogenesis, and pathology of subtypes of traumatic brain injury. Abbreviature of TBI is the abbreviature of traumatic brain injury. So let's begin from key definitions. Blunt CNS trauma. CNS is the central nervous system. So blunt CNS trauma is an injury to the head and brain produced by impact and characterized by temporary or permanent loss of brain function, which may or may not lead to organic changes in the brain. Synonym of blunt CNS trauma are traumatic brain injury, craniocerebral injury, or blunt head trauma. You can spot any of these synonyms in the medical literature, in the medical books, textbooks. You can learn on seniors courses. It is essential to understand that traumatic brain injury is a dynamic process. Means the process, the brain trauma has pathogenesis development that is initiated by the initial trauma. So the intrinsic trigger mechanism of the trauma is a mechanical damage to head. The so-called primary damage happens at the scene of the accident and determines outcome in a large proportions of the patients. So the traumatic brain injury can be primary, has two mechanisms. Primary, brain damage cannot be treated, is a fact. Primary damage of brain cannot be treated. We can only prevent the traumatic injury, but secondary injuries to the brain may have intracranial as well as extracranial causes, intracranial complications and extracranial manifestations. Avoidance and treatment of these secondary insults is the core of neurotrauma care. Neurosurgery and neurology deal with secondary injuries to the brain and secondary dysfunction of the brain that happens just after primary mechanical trauma. Pathophysiology of traumatic brain injury. Primary damage and secondary damage. As you can see on the slide, primary focus of the primary damage is smaller than focus of secondary damage, but development of secondary damages take time after primary injury. It takes from several hours to several months since the trauma. So there are three variants of primary damage. First, this is hemorrhagic contusion of brain tissue with hemorrhage into brain tissue. Disruption of vessels, this is cause of intracranial bleeding, and disruption of nerve fibers, this is etiology of diffuse axonal injury. And many complications of primary damage. They are named as secondary damages. Intracranial complications, it may be hematomas, different types of hematomas, epidural, subdural, intraventricular variants all inside the brain tissue. Brain edema as a result of dyscirculation, disorders of microvasculature in brain tissue, and rise intracranial pressure due to reducing of brain volume. And systemic insults means systemic manifestations of brain trauma, blunt brain trauma caused by systemic failure of physiological systems such as hypoxia, hypotension, coagulopathy, and delayed infectious complications such as pneumonia, hypostatic pneumonia, and septicemia as a result of bacterial contamination of, for example, wound or severe inflammatory diseases, for example, pneumonia, septic pneumonia. You should realize that the primary brain injury was defined as the irreversible pathology sustained at the time of the trauma, and primary brain injury not preventable. We cannot prevent injury of brain tissue due to primary mechanical hit. And primary treatment is not treatable. We can treat and we can manage patients in secondary brain injury. The secondary brain injury has been considered the subsequent of progressive brain damage that occurs due to an evolving pathology following the injury. And secondary damages can be avoidable, we can prevent them, and we can treat them. Mechanisms of primary injury. Now we have to discuss the difference between primary and secondary injuries. Primary injury. Acute traumatic intracranial injury which occurs during initial hit and results from displacement of anatomical structures of the brain. Mechanical application of mechanical cause produce displacement of contents of cranial cavity. The contents of the cranial cavity are brain tissue, brain structures, vessels, and liquor spaces. Brain is a movable structure, anatomical structure. The brain flowed inside the cranial cavity in the liquor, and very fast displacement of skull can cause very fast displacement of contents of the cranial cavity. So there are two mechanisms of primary damage. Coup is a brain damage caused by contact of the brain with the skull and at the point of the trauma. And counter-coup. Brain damage results from contact of the brain with the skull surface in the site opposite to the place where initial hit was applied. Pathophysiology of primary injury. What happens in the brain just after trauma? Primary mechanisms of brain damage. Three variants: cerebral contusion, shearing forces, and intracranial hemorrhage. Cerebral contusion. This may occur locally under the position of the impact, although it usually occurs more severely at a distance from the area of impact as a result of counter-coup injury. Contusion is a local lesion of brain cortex at the two places, at the place of the application of initial mechanical force and on the opposite places. As the brain is mobile within the cranial cavity, the sudden acceleration and deceleration force will result in the opposite poles of the brain being jammed against the cranial vault. For example, how to explain this position? A sudden blow to the back of the head will cause the temporal lobes to slide across the floor of the middle cranial fossa, causing contusion on the undersurface of those lobes. For example, a hit to the back of the head will cause contusion of lobes, of lobe area, lobar area, frontal area of brain due to moving of the brain, and secondary hit of the brain to internal surface of frontal part of skull. Second variant of second mechanism of primary injury is the shearing forces. Intracerebral shearing forces occur as a result of the differential brain movement following blunt trauma, frequently in conjunction with the counter-coup type of injury. The rotational acceleration flowing injury will cause shear forces that result in petechial hemorrhages, particularly in the upper brainstem, cerebellum, and corpus callosum. In those parts of CNS that fixed to the internal structure of brain, to the tentorium. Pay attention to upper brainstem, cerebrum, and corpus callosum. Those parts are fixed to the tentorium of the cranial cavity. And tearing of axons and myelin sheaths. Cracking of axons and surfaces of axons, myelin membrane of the axons cause disruption of myelin fibers, and shearing forces produce diffuse axonal injury of the brain. And last mechanism of primary damage is intracranial hemorrhage. Intracranial hemorrhage following trauma may occur as a result of severe head injury, and the hematoma will then become manifest as a further deterioration of the neurological state. It takes time, bleeding takes time for clinical manifestation, and intracranial bleeding, we can diagnose the intracranial bleeding since the lucid interval from the moment of the trauma. And secondary injury. What happens with brain after trauma, after primary damage, or after contusion, ruptured vessels, and compression of brain by blood? This is cerebral swelling. Swelling is a secondary injury to brain tissue manifested with enlargement of brain. The nature of the pathological process involves a disturbance of vasomotor tone, causing vasodilation and cerebral edema. In addition, cerebral contusion and petechial hemorrhages will contribute to the brain swelling, so enlargement of the brain. Several substances can contribute to secondary brain injury, including excitatory amino acids, cytokines, and oxygen-free radicals released during systemic inflammation. Other systemic abnormalities that contribute to secondary cerebral injury include hyperglycemia, hyperthermia, hypercapnia, and hypocapnia. So, nature of the cerebral swelling is a neurohumoral. Two parts of physiological regulatory system take into brain swelling, produce the brain swelling. Neurological, vegetative nervous system, sympathetic and parasympathetic, manifested with the disturbance of vasomotor tone, and humoral mechanism of regulation, biological active amines. Trauma is inflammation, always. Pathogenesis of the post-traumatic state includes inflammation. So inflammation produces some mediators. There are amino acids, cytokines, oxygen-free radicals, prostaglandins, leukotrienes, that act to vessels of brain and produce increased permeability of brain vessels and migration of water and proteins into brain tissue in paravasal space with enlargement of volume of the brain tissue. And secondary late complications take important role in swelling of brain. Alimentary disorders, hyperglycemia, hyperthermia, hyperglycemia, injury of gas exchange, hypercapnia, and hypocapnia is the late manifestation of pneumonia, and hyperthermia as a result of injury of central nervous system and response of body to inflammatory mediator. Histological, morphological manifestations of brain. On this slide you can see adenotic brain tissue. You can see very enlarged hairs of the brain cortex on the slide, and hemorrhage. petechial hemorrhage and presence of hemorrhagic exudate in liquor. You should differ brain swelling and brain edema to one another. Brain swelling is the overloading of intracellular space by liquid. Brain edema is the overloading of interstitial space by liquid. If the proteins and water accumulate inside the cells, this is swelling. If the water and proteins accumulate around the cells in the interstitial space, this is brain edema. Mechanisms of brain swelling and either brain swelling or brain edema. Intravascular pressure, increased intravascular pressure, and hypermobility of cerebral vessels. Swelling may be focal or diffuse, involving one or both cerebral hemispheres. It depends on localization of primary injury. Severe edema moves down cerebral hemispheres upon the tentorium, and in a few hours we can see wedging of the brain stem into foramen occipital. In the places of contact of the brain tissue with foramens and aperture of tentorium, we can find hemorrhages or necrosis. They occur in the site of the pressure. Subtypes of head injury. There are 4 subtypes of head injury: intracerebral hematoma and contusions, extracerebral hematoma, epidural or subdural or intraventricular, and diffuse axonal trauma, diffuse axonal injury. First morphological variant of the blunt craniocerebral trauma is contusion. Intracerebral hematomas and contusions are bleeding areas within the brain itself that appear as mass lesions. Brain tissue can be seen interspersed with hemorrhage on head CT scan in contusions. So the contusion is a local area saturated with blood, and this area is damaged. Cells of this area are in the center of these focus brain cells are dead, devitalized, due to ischemia and necrosis caused by compression of microvasculature by interspersed blood in this area. Contusions are often found in the frontal and temporal lobes and depends on the frequency of localization of the head trauma. Frontal and temporal lobes, the most often places of head damage. The brain may also impact the inner table of the skull across from the area of impact, thereby causing a contusion or hemorrhage. This is known as a coup contra coup lesion. So the patient has combined injury in 2 sides of the brain. In the place of trauma, in the opposite side of the place of the trauma. Coup contra coup lesion. Next morphological variant of head injury is a hematoma. Hematoma is a local accumulation of blood into cavities, tissues, or internal organs. In this particular case, blood accumulates into cranial cavity between codes of the brain. As you know, the brain has 3 codes: dura mater, arachnoid, and pia mater. In relation to localization of the hematoma, we can differentiate various types of hematoma. Epidural means the blood accumulates, blood flow presence above the dura mater. Subdural, between dura mater and arachnoid. Subarachnoid hematoma, between arachnoid and pia mater. Or intracerebral hematoma, in the blood flow presence inside the brain tissue, or intraventricular. The blood accumulates in liquor spaces in the ventricular system of the brain. Extradural synonym is epidural hematoma. On head computed tomography scans are typically hyperdense, lenticular or biconvex in shape. So we can differentiate on the CT scan, we can differentiate types of hematoma. There are cardinal signs of each variant of hematoma, and epidural hematoma is a hyperdense, lenticular or biconvex in shape, and formed by a pressure-driven separation of the dura mater from the overlying skull. The most common type of epidural hematoma occurs in the temporal region and is caused by a bleeding middle meningeal artery lacerated by a skull fracture. As was mentioned above, the most often localizations of the brain trauma, frontal and temporal lobes. In that areas, linear fractures or compound fractures of skull happen more often, and fragments of the bone tissue damage to vessels and cause the hematoma. Epidural hematoma may present with a period of normal consciousness after an initial loss of consciousness. This is lucid interval. How to understand that position? Just after trauma, the patient lost his consciousness due to initial hit, due to contusion of the brain, for example. After restoration of the consciousness in several hours, the patient lost his consciousness again. Mechanism of secondary repeated loss of consciousness is a brain compression due to intracranial hematoma, because bleeding takes the time to achieve a critical volume of the hematoma above 30 cubic centimeters is a critical to conscious state of the patient. Epidural hematoma associated with skull fracture and rupture of arteries, practically always. Hematoma is a result of bleeding. Bleeding is a result of rupture of arteries. Rupture of artery is the outcome of skull fracture, because cracking of lamina vitri can causes tearing of vessels and flowing of blood from out of vessels into epidural space. Brain often is intact. Brain remains intact because injury is superficial, not penetrated. Lamina vitri causes rupture of arteries, and deepness of injury not significant, and in many cases dura mater often intact, remains intact due to epidural hematoma. Subdural hematoma, next variant of intracranial bleeding. This is acute bleeding that is usually a result from a shearing disruption of the subdural bridging veins. Subdural means beneath the dura mater of the brain. Acute subdural hematoma is most often has crescent shape, hyperdense on head CT scan. So we can differentiate if you compare the slides. On this slide, you can see very characteristic shape of the hematoma. Crescent shape hematoma, crescent shape hyperdense shadow inside the brain cavity with displacement of median line of the brain structure to the opposite side. This is presence of foreign body. In that case, foreign body is a blood clot. On the upper photo on this slide, you can see subdural blood clot. Opened intracranial cavity and presence of blood clot under dura mater, just on the surface of the arachnoid. Subdural hematomas are frequently associated with underlying brain injury, for example, contusion or intracerebral hematomas, because dura mater is injured, ruptured, and energy of the initial hit penetrates under dura mater and can cause internal damage to brain cortex and underlying anatomical structures, because they are very tiny. Arachnoid and pia mater are very tiny brain codes, and they cannot prevent mechanical damage of brain tissue. And last morphological variant of the head injury is a diffuse axonal injury. It is a very severe, very dangerous manifestation of brain trauma. Results from shearing forces that affect the axons. This is histological injury. These axons undergo sequential focal changes, which result in axonal cytoskeletal dysfunction, followed by axonal swelling and disconnection in the hours that follow injury. In a few hours, the patient lost his disconnections of his axons in the brain tissue. Targets anatomical structures suffer the most often from diffuse axonal injury are corpus callosum, brain stem, white matter, and reticular activating system. May be affected more often than other parts of brain. In comparison, the admission head CT scan may be normal, but may also show small hemorrhages in the white matter, corpus callosum, and deep basal ganglia or brain stem. But other organic damages, contusions, bleeding, may be absent. So admission head CT scan shows practically normal structure of brain, but the patient in the coma state, his condition is very severe, and we can prognose very bad outcome of the initial trauma. The prognosis of diffuse axonal injury can be poor, and it is the leading cause of disability among survivors. Disability for many months, even years, or even for all recent life. The patient remains disabled, and he is in bed regime, in unconscious state. His life maintained with artificial ventilation of lungs and artificial stimulation of cardiac activity by artificial means. So, according to morphological changes, we can classify of blunt CNS trauma into two groups. First group is a functional injury group. States which have functional nature. This is concussion, clinical classification of brain injury, concussion, compression, contusion. The most light is the most stable state of the patient just after trauma is a concussion, manifested with temporary neurologic dysfunction, confusion, and disorientation with amnesia, characterized by transient and irreversible loss of consciousness with returns to full consciousness. Restoration of the consciousness is complete. But in some cases we can see post-concussion syndrome. Memory difficulties, dizziness, nausea, anosmia, and depression, mental depression. Second group of the traumatic brain injury is the focal insult, focal injuries. Two variants, contusion and compression. Contusion is morphologically is a region of injured brain tissue in which blood capillaries have been ruptured and clotted. In this area, we can find local ischemic place, local ischemic site. Function of this injured area will be lost. due to necrosis of cells or brain. And compression. Compression is a reduction of brain in volume caused by increased intracranial pressure. There are two mechanisms of increased intracranial pressure. High intracranial pressure happens due to compound or linear depressed skull fracture due to direct hit to the head cortex. This is Cook mechanism. Or intracranial hematoma and brain swelling. Intracranial hematoma can be epidural, subdural, subarachnoid, intracerebral, or intraventricular, or brain swelling and brain edema. Due to these mechanisms, volume of the brain tissue increases and vessels, brain circulation takes worsens due to high intracranial pressure. The first part of the lecture is finished. Please take a break for 10 minutes. After the break, we will discuss clinical assessment of traumatic brain injury. 10 minutes break, please. Neurological examination is a key point of the clinical assessment of the patients with traumatic brain injury. What is neurological assessment? This is an accurate neurological examination that will help to determine the type and position of the pathological process and provide a baseline for comparison with subsequent examinations. So, functions of the neurological examination is to assess the primary initial state of the patient, to determine his severity of his consciousness, type and localization of the pathological focus in the brain, and create a baseline, create a point for comparing of patient state in post-traumatic period. Parts of the neurological examination. Neurological examination takes 3 parts. Assessment of conscious state, assessment of pupillary size and reaction of pupils to light, and assessment discovering of focal neurological sciences in the limbs. First part of the clinical assessment is an estimation of conscious state. If the patient will respond verbally, an assessment should be made of the retrograde amnesia and post-traumatic amnesia. At first, if the patient can answer to your questions, you should find out what happens to the patient and you should assess his memory to discover of retrograde amnesia and post-traumatic amnesia. The first sign of depressed conscious state is drowsiness, at which time the patient may be easily arousable and orientated in time, place, and person. Full consciousness, but the patient is orientated, very good orientated in time, place, and his own person. As the level of consciousness deteriorates, the patient will become confused and more drowsy, stupor and sopor. Next variants of conscious state, stupor and sopor. The term coma is generally restricted to patients who show no response to external stimuli. Unconscious state, this is coma. They cannot obey commands, your commands as a doctor who examined the patient, and unable to utter comprehensible words. They cannot answer to your questions, and do not open their eyes. The Glasgow Coma Scale was designed for numerical value of consciousness. Opening and consists of 3 parts: opening of the eyes, verbal response, and motor response. You can use Glasgow Coma Scale. This is international widespread practice in neurology and neurosurgery. This scale was designed for estimation for assessment of patient's consciousness. First part of the Glasgow Coma Scale is the eye opening. If the patient opens his eye by itself, spontaneously, this is 4 points. 4 points. If the patient lie down with closed eyes and will able to open his eyes and responds to your speech, it means 3 points. If the patients do not react to your speech and can open their eyes as a response to pain stimuli, this is 2 points. And no response to pain stimuli and speech, this is 1 point. Second part of the Glasgow Coma Scale is the motor response. If the patient unconscious fully, he moves with his arms spontaneously by itself. You can ask to your patient, for example, show me your fingers, and he obeys command. He shows his fingers to you. It means 6 points, fully conscious patient. If the patient can localize this of pain stimuli, this is 5 points. If the patient cannot localize pain stimuli but withdraw his hand as a response to pain stimulation of his fingers, this is 4 points. Abnormal flexor response. The patient cannot obey your commands. He is in post-traumatic position. Abnormal flexor response, 3 points, and extensor abnormal response, this is 2 points. And third part of the Glasgow Coma Scale is a verbal response. If the patient fully oriented in his own person, place and time, this is 5 points. If the patient confused, he answered to your question, he gives wrong answers to your questions, but he can give answer. Confused conversation, this is 4 points. If the patient reacts to pain stimuli as with scream, groan, or moan, incomprehensible sounds, it means 2 points. If the patient do not produce any sounds, this is 1 point. Function of this scale. You should summarize 3 parts, points taken from 3 parts, from eye motions, from motor response and verbal response. Maximal score of the Glasgow Coma Scale, 15 points. Minimal score, 3 points. And according to some of the points, we can differentiate patient's state of his consciousness. Clear consciousness means 15 points, stupor from 15 to 11 points, sopor from 10 to 9 points, and coma state below them, less than 8 points. And all the states of the patient, traumatic brain injury with various etiology, can be divided into 3 groups: mild, moderate, and severe. At the same time, dependently on some of points taken from Glasgow Coma Scale. Classification of traumatic brain injury according to Glasgow Coma Scale into mild, moderate, and severe. Why should we classify the patient's state, clinical state? For estimation of prognosis and estimation of recovery, possibility of recovery and degree of recovery. Mild traumatic brain injury, symptoms, transient confusion and retrograde amnesia, but the patient follows commands. Prognosis is excellent, and mortality, lethality, post-traumatic period below 1%, less than 1%. Very good result. Long-term recovery. Headaches, memory problems, mostly in the first month. So post-traumatic period of rehabilitation takes a few months. If the clinical state is moderate, traumatic brain injury from 12 to 9 points, according to Glasgow Coma Scale. The patient is confused and can follow some commands. Prognosis good, enough for renewal of neurologic functions, but prognosis is near 5%. In post-traumatic period, for many months of post-traumatic period, the patient shows cognitive and behavioral deficits. Usually good recovery with treatment. If you will prescribe correct treatment to your patient, he will recover practically completely. And severe traumatic brain injury, less than 8 points, from 3 to 8 points, unable to follow commands. The patient is in coma state. His prognosis is very poor, and lethal outcome possible from 30 to 40% in post-traumatic period. The patient present in persistent coma or even vegetative state. Severe disability frequent. If the patient restores his consciousness, he will be disabled for many months and even many years after trauma. Second part of neurological examination is a assessment of pupillary size and reaction to light. Careful evaluation of the pupil size and response to light is essential at the initial clinical assessment and during further observation. Diameter of pupils is a sign of intracranial pressure. Remember, please. Diameter of pupils indicates to intracranial pressure. Raised intracranial pressure causing temporal lobe herniation. For example, temporal lobe herniation will cause compression of the third pair of intracranial nerves, resulting in pupillary dilation. This is mydriasis, which nearly always occurs initially on the side of the raised pressure. At first, mydriasis happens at the site of increased intracranial pressure. Anisocoria is the difference between diameter of pupils. On the slide you can see left eye is a normal, right eye is a dilated. Pupil is dilated due to compression of third pair of intracranial nerves. The pupil will at first remain reactive to light, but subsequently will become sluggish and then fail to respond to light at all. As the intracranial pressure increases, this same process commences on the contralateral side. If a patient has right-sided temporal hematoma, his right pupil will be dilated, but since few days, his left pupil will be dilated also, regarding to progression of intracranial pressure. And at last, you should check up oculocephalic response. If the patient has no damage of cervical spine, you can raise his head up to 30 degrees and rotates from side to side in the horizontal plane. In the normal response, the eyes maintain their position in space by moving opposite to the rotation in the head. If the patient has compromised intracranial pressure, his sight will be fixed and his eyes will be rotated similarly with his head from left to right, from right to left. This is a sign of raised intracranial pressure. And last part of the neurological examination is an assessment of focal neurological signs in the limbs. Neurological examination of the limbs will assess the tone of muscles, their power and sensation, skin sensation. Injury of the corticospinal tract and associated pathways at any point from the motor cortex to the spinal cord will result in disorders of tone, power and sensation of extremities. First variant of neurological disorder is a contralateral hemiparesis. Hemiparesis means one side of the body. If you divide the body of the patient into a vertical line, hemiparesis is impairment of function of left hand and left leg, or right leg and right arm. Hemiparesis. It means half part of the body. Second variant of the neurological disorder is the deep tendon hyperreflexia and Babinski sign on the side of injury. Babinski sign is a great toe extension and toe abduction occurs upon stroking of the sole of the foot with a blunt object. This is specific neurological sign indicates to hypersensitivity. For example, if the patient has right-sided hematoma in the temporal area, he has left-sided hemiparesis, contralateral left-sided hemiparesis, deep tendon hyperreflexia on left limbs, and positive Babinski sign on the left foot. If the patient has left-sided intracranial pathology, he will has contralateral right-sided hemiparesis, and right-sided Babinski sign. Following a severe brain injury, the limbs may adopt an abnormal posturing attitude position. It means motor response, postural position of the patient, 1 and 2 points, flexor or extensor position. The decerebrate posture means patients with dead brain. This is decerebrate posture. If the patient lie down with and his brain is dead, consists of the upper limbs abducted and internally rotated against the trunk, extended at the elbow and flexed at the wrist and fingers. When the lower limbs abducted, extended at the hip and knee with the feet plantar flexed. Feet plantar flexed means critical extension of legs, indicates to brain death. These are focal neurological sciences. Dilation of pupils and hemiparesis, focal neurological sciences. General neurological sciences are general response of brain to mechanical trauma. If the patient has functional injury, he shows general neurological sciences only, without focal pathology. Concussion is a functional state. Functional pathology occurs due to mechanical trauma, so concussion shows a functional injury. Concussion is a mild traumatic brain injury which is defined as cerebral deficit with a normal head CT scan. Organic abnormalities are absent of the head CT scan, but the patient shows neurological deficit, cerebral deficit. Concussion involves an instantaneous loss of consciousness as a result of trauma. Concussion produced by a blow on the cranium when it was free to move, and the acceleration and deceleration of the head results in shear strains, contra-cup injury, petechial and punctate hemorrhages through the brainstem, cerebral hemispheres and corpus callosum, and neuronal injury. So the degree of head injury is minimal, so the patient can recover completely due to after concussion in post-traumatic period. The retrograde amnesia of most cerebral concussion is usually short-term, lasting less than 1 day, from few minutes till 1 day. The initial retrograde amnesia may extend over a much longer period, but it gradually disappears. And finally, the patient can recover completely. We can classify all the functional symptoms according to into 4 groups. First group of symptoms, physical group of physical symptoms, manifested with headache and blurry sight, hypersensitivity to noise and light, weakness and dizziness, and problems with walk, unsteady gait in post-traumatic period, in early post-traumatic period. The patient shows unsteady gait, he cannot, he feels very weak, he feels itself very weak and dizzy, and he has a very expressive reaction to noise and to light. He tries to avoid to light and noise. Second group of symptoms, cognition or memory disorders. The patient a few days cannot think clear, he feeling slowed down, his motions are very slow, and he has some troubles with reality, awareness and memory during this period. Third group of symptoms, emotional disorders. Some patients show depressive state, nervousness, or anxiety in post-traumatic period. And sleep disorders, interruptions in normal sleep patterns. The patient sleep very sleepy during the day and cannot fall asleep in night. This is inversion of normal sleep patterns. Imaging studies due to primary neurological assessment. You should perform imaging studies. You should have documents of patient's state of his brain and functions, neurological functions. For documentation for improvement of patient state, you should use some additional methods of examinations. First method of examination is skull X-ray. In the past, all the patients with a suspected head injury underwent skull X-ray series in two views, anterior, posterior, and lateral X-ray examination. This practice is currently replaced by the use of CT scan, head CT scan, computed tomography. A skull series may, however, still be useful in skeletal surveys and to assess depressed skull fracture or craniofacial trauma. If the patient sustained for depression skull fracture, you can prescribe the skull X-ray, or for diagnosing of fracture of face, bones of face, you can also prescribe the skull X-ray. Computed tomography of the head. Nowadays, this is golden standard of patient's examination. Head CT scan is the emergency imaging technique of choice after head injury. Very widespread method of examination, very simple, enough simple for clinical hospitals. Now each hospital has machines for CT scanning of the body. And this imaging study is done without contrast examination. No injection of no contrast needed intravenously. You must prescribe native computed tomography of the head. Acute blood is visible as the hyperdensity area. For differential diagnostic of hypodensive and hyperdensive intracranial formations. So we can diagnose bone pathology, fractures, compound or simple impressed fractures, or presence of intracranial foreign bodies such as blood clots. Or we can diagnose previous concomitant states, previously existed diseases of brain such as cysts, tumors, and other foreign bodies, for example. Angiographic studies. The cerebral vasculature can be evaluated using arteriography. Formal arteriography, native arteriography, CT scan, angiography, or magnetic resonance angiography, or venography. We can perform injection of contrast into vessels, into cerebral vessels, and we can visualize of pattern of intracranial pattern of vasculature. We can diagnose, we can find place of rupture of vessels, and we can define places of ischemia, intracranial ischemia. And last method of examination is the magnetic resonance imaging of the head, MRI. It's a very useful method for assessment of structure of brain in late post-traumatic period. May be useful in diagnosing of subacute or chronic phases after injury. For example, diffuse axonal injury. Third part of the lecture is devoted to management of patients with traumatic brain injury. Management of patients takes three parts. First part of management is pre-hospital care. Pre-hospital care. This is initial medical help, medical service. You must render initial pre-hospital care in the scene of the trauma, in the scene of the accident. At first, maintenance of airway, mask ventilation or tracheal intubation, or any subsidiary methods, indirect methods of lung ventilation, mouth to mouth or mouth to nose, for maintenance of patients' breathing, gas exchange. Next action is spine immobilization, full cervical spine immobilization. Head and cervical part of spine should be immobile during transportation of the patient to avoid of secondary damages of brain tissue due to displacement, for example, displacement of bone fragments and injury of brain tissue with very sharp bone fragments. Cardiovascular support with fluid resuscitation should be sufficient to maintain cerebral perfusion. You should maintain patients' blood pressure above 90 millimeters of mercury to maintain his brain circulation, to avoid his brain hypoxia. And in that position, you should deliver the victim of the patient into nearest clinical hospital. If you have specialized traumatological or neurosurgical hospital near the place of accident, you should transport, preferably transport of your patient to this specialized hospital to reduce time of rendering of specialized medical treatment to the patient. Second part of the treatment, medical care, is operative treatment, surgical operation. Not any head trauma should be operated on. You should estimate indications for surgery. There are three indications for surgery. Simple depressed fractures that require surgical intervention if they cause a significant mass effect. Depressed fractures. Compound fractures. Simple fractures with the depression of bone fragments, and compound fractures with depression of bone fragments. Simple depressed fracture. If the bone fragments are depressed more than 1 centimeter below the adjacent intact skull, or if the linear simple fracture accompanied by a hematoma beneath the line of the fracture, epidural hematoma. What should you do with the patient? The depressed fragments should be removed. The dura is inspected and closed if necessary. If the dura mater is damaged, you should stitch the dura mater, close it. And if the bone fragments keep their blood supply, with periosteum, you should reimplantate the bone fragments into their initial position and fix them to avoid the secondary displacement in the postoperative period. If the fracture is compound, multiple fractures, with the association with infection and epilepsy, elevation of the fracture of the bone fragments, debridement of the wound, removal of the bone fragments and meticulous closure of the dura, and draining of the postoperative site. And the patient with intracranial hematoma, presence of blood clot into cranial cavity. Not any blood clot demands surgical intervention. If a thickness of the blood clot greater than 10 millimeters on the CT scan. You can calculate the thickness of the hematoma on CT scan. If the thickness greater than 10 millimeters, this is indication for surgery. If any hematoma causes a midline shift more than 5 millimeters to the opposite side, also indication for surgery. And if the hematoma with volume greater than 30 cubic centimeters. These are indications for immediate, urgent trepanation of the skull and management with brain tissue and contents of the cranial cavity. Technique of the operation, surgical operation for depressed fracture of skull. Compound depressed fracture. Bone fragments are involved into cranial cavity, and you can see compression of brain, compression of cortex, contusion of cortex, and presence of hematoma above fragments of bone tissue, between bone fragments and beneath the bone fragments. Between skull and brain cortex there is a blood clot. In this particular place, bone fragments will produce constant pressure. Constant pressure to brain cortex causes hypoxia, ischemia, and late necrosis of brain tissue. To avoid all the long-term compression in the post-operative period, you must operate on the patient. Approach to the ischemic center is a direct elliptical incision with extensions to remove the vitalized skin and pericranial. Paravalvular soft tissues that are devitalized and saturated with blood, we should remove. We should perform primary surgical treatment of wound if the patient has wound. Or we should simply remove the bone fragments. We should remove the cause of intracranial hypertension. Method of name of the operation: decompressive craniectomy. Decompressive craniectomy. You must remove the bone fragments, make the impressed surface even, and you should expect the dura matter of the brain for any damage. If the hematoma is present, you must evacuate of the hematoma. You must lave of the wound with antiseptic saline, with sterile saline solution. Sterile saline solution, and stitch the dura mater if the layer is damaged. After that, you can close the wound with stitching of skin, subcutaneous fatty tissue, and aponeurosis, and prescribe the post-operative treatment scheme of the post-operative conservative management. If the patient has epidural hematoma, name of the operation: osteoplastic craniotomy. Osteoplastic craniotomy. The surgical approach is very anatomic for the patient. In the post-operative period, structure of the skull is kept. The doctor performs osteoplastic trepanation for temporal opening of the epidural space and evacuation of the hematoma. After suction of the hematoma with vacuum aspirator, if the dura mater is intact, the doctor put the osteoplastic flap, muscular and bone flap into its initial position, and close the surgical approach with skin stitches. In the post-operative period, the operative site should be drained with flowing or passive drainage to remove the post-operative fluid. postoperative interstitial fluid which accumulates in the traumatic site and cause secondary compression of the brain structures. And if the patient has subdural hematoma, the surgical approach is the same to approach for epidural hematoma, but the doctor must open, the surgeon must open dural matter, revise the subdural space very carefully, assess extensiveness of the hematoma, remove the blood clots, lay the intracranial subdural space with sterile worm saline solution, and very meticulously close the operative site with stitching of the dural matter and drainage of the surgical approach. In the post-operative period, we must prescribe intensive care management of brain injury. Third part of the treatment is intensive care management. If the patient does not have any indications for surgery, he should be hospitalized in intensive care department directly for immediate intensive care management. Neuromonitoring and neuroobservation have two primary goals. The patient must be sustained under neuromonitoring in intensive care department. What is a monitoring? It is a constant checking of his parameters, physiological parameters of the patient. Functions of the neuromonitoring. Very rapidly identify neurologic deterioration. As soon as possible, we must assess of the initial patient state, and in post-traumatic period, we must compare all the patient state to his initial state for timely correction of post-operative or intensive care treatment. To avoid secondary brain injury, to rapidly identify neurologic deterioration, and to avoid secondary brain injury. If the patient's state worsens in post-traumatic period despite the correct intensive care treatment, it means the patient has intracranial complications, and we must reassess his state again more carefully and maybe perform some additional methods of examination to diagnose, to discover the intracranial complications. Optimal intracranial unit management of the brain injury patient involves the continuous monitoring of physiological parameters such as heart rate, ECG, electrocardiography, blood pressure, body temperature, and volume status, and pulse oximetry. Pulse oximetry is a measuring of gases, partial pressure of gases in peripheral blood of the patient. I mean partial pressure of carbon dioxide and oxygen. If the patient has hypoxic state, we must perform artificial ventilation of lungs, and ventilation should be titrated. The regime of ventilation should be adjusted for maintaining of partial pressure of carbon dioxide above 45 mm mercury, and to maintain the arterial saturation of 93% or greater. We must avoid hypoxic state of the organism in the post-traumatic period to avoid of brain edema. Arterial blood pressure monitoring should be continuous, and mean arterial blood pressure should be maintained above 80 mm mercury to avoid of brain hypercirculation. And patients should be kept euvolemic to avoid hypotension. Isotonic fluids are preferable because dextrose containing hypotonic solutions may aggravate brain edema. What it means? Glucose solution is based on hypotonic solution. Hypotonic, below than 0.9% of sodium chloride. Hypotonic solution. After utilization of molecule of glucose, volume of infused solution becomes hypotonic and migrates into brain tissue along the difference of osmotic concentrations in blood and tissues. After the neurological monitoring has been estimated, we must prescribe conservative treatment, intensive care. First point of the conservative treatment is analgesia and sedation. We must sedate brain activity and control pain. Why? So we must control the pain, because pain is a trigger mechanism for vasoconstriction. Vasoconstriction means depletion of blood supply to brain tissue, and may aggravate post-traumatic brain edema. Sedate brain activity. Why is it so important? Brain activity should be sedated to reduce metabolism of brain. When the metabolic rate becomes slow, the demand of oxygen to brain tissue will be reduced, and secondary injury to brain tissue will be minimal. Second point of the treatment, anticonvulsants, drugs for reducing electrical activity of the brain, very indicated in great risk of post-traumatic epilepsy in case of intracranial hematoma or depressed skull fracture. If the patients show early seizure, occurs within the first week since the trauma, it means local brain activity is increased, and we must suppress the extrafocal brain activity with anticonvulsants. Temperature control, very important. In the post-traumatic period, the patient falls into hyperthermia state due to irritation of centers of thermoregulation into brain, and due to systemic inflammatory response to trauma. Hypothermia can increase the cerebral metabolic rate and aggravate unfavorable outcome. Shivering and profound hypothermia can aggravate rise of intracranial pressure, and so temperature control is very important. We should keep the patient's body temperature within the normal range to avoid secondary damage of the brain tissue. And very important, the most important method of treatment of traumatic brain injury is a correction of intracranial hypertension. How to recognize of intracranial hypertension? We can measure of the intracranial hypertension by Dopplerography, and any patient shows rise of intracranial hypertension above 20 millimeters of mercury should be treated with dehydration therapy. Any patient with bilaterally dilated and non-reactive pupils. Dilation of pupils means compression of third intracranial nerves, third pair of intracranial nerves. So the patient is hypertensive. And comatose patients who initially has normal reactive pupils but shows asymmetric dilation of pupil with or without hemiparesis in the post-traumatic period. All these parameters indicate to rise intracranial pressure. And actually, what can we do for the patient to reduce his intracranial pressure? Curative measures. 3 steps. First step of hypotensive therapy is diuretic therapy. Prescription of diuretics with intermittent administration of mannitol or furosemide. Mannitol is an osmotic diuretic and may also exert its effect by increasing serum osmolality and drawing water out of the brain. Osmolality of blood increases, and along the osmotic concentrate gradient of osmotic concentration, excessive amount of water will attract from brain tissue into blood. After that, after the increased osmolality, after the osmolality will be increased by mannitol, you must prescribe furosemide. It's a direct diuretic which removes excessive volume of water from blood through kidney. Second step of the hypotensive therapy. Prescription of barbiturates, drugs for intravenous narcosis. Barbiturate therapy can be considered if the intracranial pressure is resistant to treatment with diuretics, sedative drugs, analgesics. We must prescribe derivatives of barbituric acid, for example, pentobarbital or thiopental. Bolus treatment of the bolus injection of these drugs into blood frequently effective in temporary reducing of intracranial pressure. If, despite the mentioned above measures, intracranial pressure is critically raised, we should perform decompressive cranioectomy. This is last step of curative measures, surgical operation. Decompressive cranioectomy involving removal of large area of cranial vault from the frontal and temporal regions, bilaterally, and can be useful as a means of controlling raised intracranial pressure due to severe cerebral swelling following a head injury. If the conservative therapy will be ineffective, will produce no positive effect, we should prescribe decompressive cranioectomy to avoid of secondary death of brain by raised intracranial pressure. This is last slide of the lecture, and actually this is last lecture for this semester. If you have some questions, you can ask me in the chat. If you have no questions, you can be free. I wish you every success for exams, winter exams, and zachets. And next time we will see. We will see together in next semester. Please, if you have questions, ask me, please. So there is no questions, so the lecture course is finished today. See you next semester.